the third session. And really, perhaps you know that the transesophageal echo usually is and commonly being used in our theaters for the assessment of the valvular lesions, the valvular abnormalities, as well as to assess the mechanical valves in the cardiac theaters, and as well as the critical care settings as well. However, definitely it might be require a specialist and someone who have a very particular experience to go with the transthoracic echo any state, especially if you have some contraindications or sometimes with the TOE. Definitely we had to really prepare a very particular settings. The patient might need sedation or a GA. But definitely, if you have the accessibility to go with a transthoracic echo, if you have a very good experience in that, actually this would bypass those settings. And that's why here we have our Professor Dr. Ahmed Hegazy. He's Assistant Professor of Anesthetics and Critically Ill Management or Critical Care Management from Western University, London, Ontario, Canada. I think he will reflect a very wide his very wide experience and his outstanding input in this field over the next presentation. Dr. Ahmed Hegazy have been trained in the anesthetics and the ICU in Canada. He have a very wide experience in the field of the neuroanaesthesia and in the management of intensive care medicine, especially in the University of Western Ontario. He actually have a master's in the public health. He's been board certified in the field of the transesophageal echo and the ultrasound, and definitely he has also a broad experience in the field of the ultrasound, as well as the teaching in many national and international conferences and events. His main area of interest is in the post-cardiac surgery care. And definitely, I'll be very ambitious personally to compare and try to tailor my experience based on this presentation. So thank you very much, and a very great welcome for you, Dr. Ahmed, across the Atlantic. Over to you.
Thank you, Dr. Al-Gamil. I appreciate this great introduction. Can everybody hear me okay?
I'm hearing you fantastically.
Perfect. Okay. Thank you so much for having me today. It's a privilege, and I appreciate the invitation, Dr. Mahdi, as well. And it's a pleasure to be with all of you today. So I'm going to talk to you about focused transthoracic echocardiography with regards specifically to valve assessments in the ICU. And to those who attended the last talk, which was 2 weeks ago, we went through the basic views and what you can benefit from when you're doing a transthoracic echo, but we did not cover specifically the portion about valve assessment. So that's what I look forward to presenting today. I have no financial disclosures to disclose, so I do not receive any funding from any of the ultrasound vendors. And in terms of the outline, I will cover general principles about valve assessment in transthoracic, in the world of transthoracic echo. I'll also go through point of care valve assessment, specifically the aortic and the mitral valves, which tend to have a high impact on how we manage patients in the ICU. And I'll cover some clinical vignettes, cases where ultrasound actually did make a difference in how we manage these patients and actually affected the patient trajectory. So let's start off with general principles. I'll define first the scope. And by that, I will refer to the American College of Chest Physician Guideline Statement that was published in 2009 by Dr. Paul Mayo and his colleagues, where he actually defined basic critical care ultrasound competency when it comes to valves as being identification of acute, massive, left-sided valvular regurgitation. So basically, the scope here was narrowed down to acute, massive, left-sided, so we're talking aortic and mitral valve regurgitation in the medical ICU population. And basically, the general principles that are involved in examining any valve from a transthoracic standpoint You start off always by examining the valve in 2D mode. So you really need to establish what the morphology of the valve looks like by 2D before you move on to color. And you need to assess the valve in multiple views. So in 2D mode, you will be able to understand whether the valve looks normal, whether it opens okay, closes okay, whether there's prolapse, there's a flail leaflet, there's a vegetation, there's a perforation. So there's multiple pieces of information that you will actually understand by first doing your 2D exam and then moving on to your color Doppler. But don't rush into color Doppler. First, look at the valve, assess its 2D morphology, and then move on. Multiple views are usually needed to confirm your diagnosis. And then you move on to apply color Doppler and assess whether there's any regurgitation. And color Doppler can also be useful if there's turbulence post-valve in assessing for stenosis. And then you assess your findings in the context of chamber size and function. So what I mean by that is certain lesions, for example, if we talk about mitral regurgitation, if you have chronic mitral regurgitation with time, the left atrium tends to enlarge slowly and accommodate the excess volume. And the symptoms tend to develop gradually with a progressive course. Whereas if you have an acute mitral regurgitation, say for example, you have a patient with an acute myocardial infarction, a ruptured papillary muscle, and a flail leaflet of the mitral valve. These patients usually present in extremis. They usually present in florid pulmonary edema because of the acuity of the presentation. The left atrium does not have does not have time to enlarge in size. So what you end up with is an acute increase in left atrial pressure and pulmonary edema with a normal sized left atrium because it really never had a chance to accommodate that extra blood. In terms of color Doppler examination, color Doppler gives us a lot of information. Color Doppler gives you an indication of the velocity of flow and the direction of flow. Is the flow going towards the probe or is the flow going away from the probe? And the generic color map that we use by general convention is the blue away, red towards convention. And that's usually referred to as the BART convention, blue away, red towards. And the brighter the color, the brighter the hue of blue, the faster the flow. And the brighter the red, and even some of these scales will have a yellow. The yellow means it's faster. The red means it's slower. The light blue means it's faster. The dark blue means it's slower. So it actually gives you an idea of both direction and velocity. And it's most accurate when you're scanning parallel to blood flow. So you need to establish what your angle is, how your ultrasound beam is aligning with the flow of blood. And it tends to be most accurate when the flow of blood aligns parallel to your ultrasound beam. So here is a generic color flow Doppler map. You notice here that we have our scale in the top left-hand corner, and this scale is referred to as the Nyquist limit. And what the Nyquist limit is, it's basically the maximum velocity that the probe can detect accurately. So anything less than 67 centimeters per second of a velocity will be detected accurately by this probe. And if it's going towards the probe, it'll be red or yellow. If it's going away from the probe, it'll be blue. So the Nyquist limit is the maximum velocity the probe can detect with accuracy. And you usually set it to 50 to 70 centimeters per second if you're trying to assess valves in general. These are the recommendations of the American Society of Echo. And consider here in this parasternal, in this apical four-chamber view, consider in this apical four-chamber view how your mitral regurgitation jet is going. So its direction is away from your probe. So that's why it looks blue. And your ultrasound beam is relatively parallel to the actual regurgitant flow. It's a little bit off, but not too bad. It's within 20 degrees of the regurgitant flow, which is ideal. And so this is actually good alignment with your regurgitant jet. And the accuracy is obviously improved when you're more aligned. And the color box should also include the receiving chamber. And what I mean by the color box is this box here that shows us where the color is being displayed. Essentially, color Doppler is a bunch of pulse wave Dopplers in a box, and it detects flow of blood within that color box. So make sure that when you are setting your color box that it includes the regurgitant chamber, the chamber that is receiving your jet. Example, in this case of mitral regurgitation, you're interested if the flow is going back into the left atrium, and so your color Doppler box should include the left atrium. So what happens if blood velocity exceeds the Nyquist limit? So we've set the Nyquist limit here at 67 centimeters per second. What if our jet is going at 70 or 80 or 90 centimeters per second? What will the probe, what will your ultrasound machine show the flow to look like? Essentially, this is when aliasing happens. An alias is a term that describes when ultrasound velocity and direction is not being accurately depicted by your ultrasound machine. Let me tell you an example here. So say, for example, you're looking at a wheel as the train is starting to take off or as the vehicle is starting to move. You look at the wheel and the wheel is turning, and it's turning in a certain direction until the speed picks up. And once the speed is really fast, the wheel starts looking to you like it's going backwards. And the reason for that is the shutter speed of your eyes is slower than the movement of the wheel. And so because your shutter speed is slower, you start seeing the wheel move backwards. And so you're not accurately detecting where it's moving just because your shutter speed is too slow. And so by the same example here, if the flow is fast, what will happen is this mosaic pattern. It will not be able to determine where this flow is going, and it will basically be flipping back and forth between the two colors. It'll be flipping between the yellow and the blue. This happens when the velocity speed, with the jet speed, is much higher than your Nyquist limit. It also happens when you have turbulence. So when there's a stenosis and there's turbulence, you'll also see this aliasing or mosaic pattern on color Doppler. So let's move on to some specific examples and how you would assess the aortic valve specifically. So in terms of assessing the aortic valve, we mentioned last time the 5 basic views. And out of these 5 basic views, the one that shows you the aortic valve is the peristernal long axis. So here we're showing the peristernal long axis. You see the aortic valve here in the near field, and you see the left atrium down in the far field. Another view that we'll sometimes use to assess the aortic valve is the apical 5-chamber view. So when you first assess it, you'll assess it in 2D in the peristernal long axis, and then you'll assess using color Doppler in the peristernal long axis. Another view here, as I mentioned, is the apical 5-chamber. Now, what is the apical 5-chamber? Basically, it is, you get an apical 4-chamber first, and from the apical 4-chamber, you actually shallow your angle a bit. And what I mean by shallow your angle, let's imagine where the aortic valve is located in the chest. The aortic valve is an anterior structure in the chest. And so what you need to do, if your angle with your probe in the apical 4-chamber is steep, you need to make your angle more shallow, and that way you'll start seeing the LVOT come into view, and you'll also start seeing the aortic valve come into view. And we call that the apical 5-chamber, and you get that from initially the 4-chamber view and then tilting your probe to a shallower angle. The 5th chamber is the LVOT. That's why we call it an apical 5-chamber, and this is the aortic valve that you can see here. And so this gives you good alignment if you want to do color Doppler and assess velocities. So what does the normal aortic valve look like? It basically looks, as you can see here, very thin, very pliable. It opens well, and it opens at least 8 millimeters. And so this looks like a normal aortic valve. You put color Doppler on it, and you don't see any regurgitation. So this is normal flow. It's all laminar. There's no turbulence. And then after you do your 2D examination, you start assessing with color Doppler. When you have, for example, when you're suspecting, for example, aortic incompetence, you want the color Doppler box to involve the left ventricular outflow tract, because that's where the regurgitant jet will be heading. Now, mind you, looking at this peristernal long axis view, what you see here is an aortic valve that looks quite calcified, and it's not opening well. When you compare it to the previous view, this is not a healthy looking aortic valve. It's not opening very well. So I suspect there will likely be some degree of aortic stenosis there. You would need continuous wave or pulse wave to assess fully how much stenosis you're dealing with. But let's go back to aortic incompetence though. So we're trying to assess for aortic incompetence in this patient, and we're putting the color box on the aortic valve, and we're looking at whether there's a jet going back into the left ventricular outflow tract. And you see here, there's a jet going back into the left ventricular outflow tract. And so there is aortic incompetence in this image. How do you quantify whether this aortic incompetence is severe or non-severe? In the critical care setting, when you're dealing with a patient with undifferentiated cardiorespiratory shock or a cardiorespiratory failure or basically circulatory shock, if you're dealing with a patient in shock, you really want to understand what is the cause of shock. Is it LV failure? Is it a catastrophic valvulopathy? And so you basically want to do a point of care cardiac exam for any patient presenting in shock in the ICU. And in this patient here, what we see is we see a bit of aortic incompetence. How do you grade its severity? You can look at the height of the jet and whether the jet height in comparison to the LVOT height constitutes more than 65%. So if that jet height is greater than 65% of the LVOT height, that is an indicator of severe aortic incompetence. If it's less than 65%, that would indicate a non-severe lesion. And that's what I mean by LVOT height. You would compare the jet height to the LVOT height, and 65% is your cutoff for severe. And then you move on to here to assessing for aortic stenosis. And even though it's beyond the scope of basic point of care transthoracic echo, I will talk a little bit about aortic stenosis just because it's an important lesion. It's something that we care about, and it affects our management both in the ICU and in the operating room. And so when you compare here the aortic valve on the left-hand side, this is a completely normal aortic valve, to the aortic valve on the right-hand side. This looks like a calcified aortic valve that is not opening very well. And the orientation is a little bit off in this peristernal long axis, but you see here that the left atrium is also enlarged in size. This is a very big left atrium. Left ventricle is over here, and you see that the aortic valve is not opening very well. I would be very suspicious for that aortic stenosis is likely present here. This is a more clear view of what aortic stenosis really would look like. And so you see here how this aortic valve is heavily calcified and it's not opening very well, very restricted. And the other thing that jumps at you when you look at this view is that the left ventricular systolic function is severely depressed. So this is a patient with a severely depressed LV. So not only does he have severe aortic stenosis, likely severe aortic stenosis, we haven't really quantified that yet, but based on this image, we likely do have some degree of significant aortic stenosis. We also have LV systolic dysfunction as well. So here you can compare both valves. This is the normal valve, this is the calcified valve. Quite the distinction, quite the hyperechoic calcified valve you see in the bottom right-hand corner there. The reason I go through 2D examination quite thoroughly is that we mentioned this last time, but I'm going to say it again. An aortic valve that appears normal with normal leaflet mobility rules out severe aortic stenosis with 99% sensitivity. So if you look at the aortic valve just based on a transthoracic point of care TTE, and you look and you see the aortic valve is thin, it's pliable, it's opening well, it's extremely, extremely unlikely that this patient has any degree of severe aortic stenosis. In fact, you rule it out with about 99% sensitivity. Now, when you want to understand further, or maybe confirm to yourself, is there some degree of aortic stenosis in this view? One thing you can do is put color Doppler and then look at the aortic root and see if there's any turbulence. Remember, as flow goes through any stenosis or any constriction, it will accelerate. And as it accelerates, you will exceed your Nyquist limit and you will start getting turbulence. And so what we see here is turbulence beyond the valve due to aliasing. And that is because there is aortic stenosis in this patient. Further interrogation, if you want to understand the peak velocity, the peak gradients and the mean gradients, you'll need continuous wave Doppler. And if you need to understand the aortic valve area, then you can calculate that using the continuity equation, and you'll need for that pulse wave Doppler. So you'll need further advanced training if you want to apply pulse wave and continuous wave. But this, in my mind, if you see a valve that is calcified, not opening, with turbulence post-valve, you've got your diagnosis. This patient likely has some degree of severe aortic stenosis. You need further advanced interrogation to further quantify. And the reason I like to talk about aortic stenosis is because of how significant an impact it has on patient survival. When you look at patients who have aortic stenosis who have not undergone any surgery, their natural history is such that over time, they have a bit of a latent period where there's increasing obstruction, a bit of myocardial overload that's building up over time as the aortic stenosis gets more and more severe until it eventually starts becoming symptomatic. And once the patient becomes symptomatic, that's when their lifespan is affected. And it depends on how they present with regards to symptoms. So if they present with angina, for example, they have a 5-year average survival. If they present with syncope, then they have a 3-year average survival without surgery. If they present with congestive heart failure or dyspnea, then they have a 2-year average survival without surgery. And that is the reason symptomatic aortic stenosis is an indication for valve replacement. It's because you do obtain a survival benefit when you actually replace the aortic valve in somebody with symptomatic severe aortic stenosis. And you can see here, if you're presenting congestive heart failure, the survival is actually not that great. It's only, the average survival is 2 years. I'll move on to the mitral valve. So how do you assess the mitral valve by transthoracic echo? For point of care purposes in the ICU, you have 3 views where you can assess the mitral valve. The first is the parasternal long axis. And you see the mitral valve here in the far field between the left atrium and the left ventricle. The second is the apical 4-chamber view, where you see the mitral valve between the left ventricle and left atrium. And the third view is your subcostal 4-chamber view, where you see the mitral valve in the far field. And a lot of times your subcostal 4-chamber view in a ventilated patients with high PEEPs is sometimes your best view, because your liver is your acoustic window and you're not having to go through lungs and negotiate the lungs. And so a lot of times the parasternal, the subcostal 4-chamber is a very helpful view in patients on high PEEPs. So you assess first using 2D assessment. You look at the valve. What does it look like? Does it look normal? Does it look perforated? Is there vegetation on it? And then you put color Doppler on it and assess. And the apical 4-chamber view tends to have very good alignment with your flow. Remember, if your flow is going normally from the left atrium to the left ventricle during diastole, then that aligns well with your ultrasound beam. If there's regurgitation, it will also align with your ultrasound beam, except that it will be going in the opposite direction. During systole, you'll find that there's a regurgitant jet going from the LV to the LA. So again, there's the mitral valve right here in the far field. What I want to draw your attention to is that the mitral valve, when it opens during diastole, the anterior leaflet here goes up and it approximates the septum. That is a normal finding. Normally during diastole, as the mitral valve opens, the anterior leaflet will go up and approximate the septum. Normally it will come close to the septum to about up to 1 centimeter to the septum. Or normally it's actually 1 centimeter or less from the septum. So we call that the E-point septal separation distance. So it should be less than 1 centimeter from the septum during diastole. You put color flow on it and there's no regurgitation there, so that looks normal. And then here you put color flow again on this. This is a different patient, and you see here that there is mitral incompetence, and it looks like it's anywhere from mild to moderate. At the very minimum, it's mild, but it's likely more in the moderate range. You'd need further testing to quantify, and we'll go through that in a second. Now, looking here at your mitral valve again in this apical 4-chamber view, what you see here is the valve looks reasonable, except that it's not opening a whole lot. And when you put color on it, there is a degree of mitral incompetence here. Now, mind you, one thing that also comes to mind looking at this view is that the LV systolic function is quite impaired, and the LV looks quite large as well. So there's LV enlargement, and there's also mitral regurgitation. This is actually an example of a functional mitral regurgitation. This patient had end-stage heart failure, had a dilated left ventricle, and this caused tethering of the chorda tendineae and a slight annular dilatation, which gave you mitral incompetence. This is a functional MR. It's not related to intrinsic mitral valve pathology. It's more related to the heart failure. Contrast the previous image with this one here, where you see severe MR. Look at this jet and how it fills up the entire left atrium. And so this is a prime example of severe mitral regurgitation. And if you want to understand whether this regurgitation is significant or severe or non-severe, you can assess the jet area. You'd have to pause your view and trace the jet area and see whether it occupies 50% of the left atrium. So if your jet area is greater than 50% of your left atrial area, that is the cutoff for severe mitral incompetence. Or the other thing that you may find, if you have an eccentric wall-hugging jet, that is by default also a severe mitral incompetence. Wall-hugging jets are always by default more severe than you think they are, and they're always related to some degree of valve pathology. A lot of times an eccentric jet is related to ipsilateral leaflet restriction or contralateral leaflet hypermobility. So a lot of times eccentric wall-hugging jets are related to intrinsic valve pathology. And they are by default considered severe because if they're wall-hugging, you're probably not cutting them in their entirety, but they're probably spanning the entire wall. And so by default, they will be considered severe. Another way to assess whether your mitral incompetence is severe or not is by measuring the vena contracta. And the cutoff for the vena contracta here is 7 millimeters. What is the vena contracta? I'll go through that in a couple of slides. So here I show an example of an eccentric MR jet. And because it's an eccentric wall-hugging jet that reaches all the way to the back of the left atrium, this is by default considered a severe MR jet. As I said, it could be either restriction of this posterior leaflet or hypermobility of the anterior leaflet. And so what is the vena contracta? So let's go back to what we mentioned there. The vena contracta basically is a surrogate for the effective regurgitant orifice area. So what is that? So when you look at the pathology in a patient with mitral regurgitation, the mitral valve is leaky. There is backward flow going from the left ventricle to the left atrium during systole, where you would normally expect the mitral valve to be closed during systole. Here with incompetence, there is backward flow going from left ventricle to the left atrium during systole because there is a regurgitant orifice. And what happens here is flow converges onto that orifice during systole. As the ventricle contracts, there will be a proximal flow convergence. And then there will be a tight spot, a narrow point where the flow is going back into the left atrium. And then beyond that narrow point between the two leaflet tips, you will find that the distal jet will expand again and the flow will diverge again. And so what you see here is a flow convergence, a vena contracta, and then a flow divergence beyond the orifice. And so that is that narrowest point of flow is what we call the vena contracta, and that is what you're interested in measuring. And if that is 7 millimeters and above, that is the cutoff for severe mitral incompetence. And so I'm showing you here how we normally would measure a vena contracta. Here I'm looking at an apical 4-chamber view. I'm zooming into the mitral valve. I've got my color box there. I'm moving it over to try to get more of the left atrium, and then I rotate my probe a bit to try to get the mitral valve right in the middle. I pause my image, and then I scroll over until I see the jet. And then once I see the jet, I put my cursor, and then I measure the narrowest point of that jet just before the jet diverges. And what I see here is 0.3 centimeters or 3 millimeters. So that would be in the range of mild to moderate MR. So again, how do we quantify severe mitral regurgitation? So first of all, you look at the valve in 2D. You assess whether the valve looks normal or whether there looks like there is primary valve pathology, whether it's flail, there's a vegetation, there's retraction, there's a perforation. Or the valve may still look normal, but you may still have functional MR, secondary MR, and that is usually due to severe tenting and poor leaflet coaptation. Usually we see that with LV dilatation in cases of heart failure. Then you put the color box on. Remember, you want to include your left atrium because that's the receiving chamber for your jet. And you want to assess whether that jet looks significant enough. If it's more than 50% of the left atrium, that is considered severe. Or if the vena contracta is greater than or equal to 0.7 centimeters, that is considered severe. Or if it is an eccentric jet that is swirling in the left atrium and hugging the wall and reaching all the way to the back, that by default is also severe. And then you can move on to spectral Doppler. Spectral Doppler is not that difficult to do. It just requires a bit of training. You need to be very familiar with continuous wave and pulse wave and the limitations of both techniques in order to be able to move on to the advanced MR interrogation techniques. And obviously you can do things like calculate regurgitant volumes, regurgitant fractions. Systolic flow reversal in the pulmonary veins is one that I like to do quite a bit. Now, obviously, these are more advanced techniques that are beyond the scope of basic valve assessment in the ICU. Okay, so the tricuspid valve follows a similar pattern. You apply the same concepts. So you look at the tricuspid valve in 2D, and then you put color on it. There's no tricuspid regurgitation in this apical 4-chamber view. Here, however, you see quite a bit of tricuspid regurgitation on color Doppler. It's at least in the mild to moderate, I'd say at least moderate, I would say, based on the amount of regurgitation we're seeing there, and it would need further quantification. And here you see also at least moderate to severe tricuspid incompetence. So let's go through some clinical vignettes. I don't have too much to go through here, but I will go through a few clinical vignettes that were actually ultrasound helped in the ICU navigate patient management. So our first patient here is a real patient. It was a 55-year-old gentleman who presented to a peripheral hospital with a 3-day history of cough and shortness of breath. In the peripheral hospital, they thought he had a pneumonia. They sent him home with antibiotics. He came back to hospital the next day with increasing shortness of breath. And they felt that his pneumonia had progressed enough, and they called us as a tertiary center for referral, and they had basically transferred the patient over to us in the ICU with a working diagnosis of pneumonia, which had progressed to ARDS. And that was their working diagnosis on admission. So the patient was in cardiorespiratory failure. He was intubated. He was on pressors. And so what we did is, as for any patient we get in the ICU who's on pressors, we did an initial point of care transthoracic echo assessment. And this is our subcostal 4-chamber view. And what you see here is the left ventricle in the far field, the left atrium, and you see the mitral valve in between. This contour of the base of the left ventricle looks somewhat abnormal. And so I will get to that in a second, but normally left ventricular endocardial border is more smooth, and you don't see this outpouching at the base of the left ventricle. Here, I'm looking at a peristernal short axis. It looks like the contractility at the mid-papillary level is normal. This is quite pleasing. But then as I tilt my probe up in a peristernal short axis at the basal level, here I see more the mitral valve. At the basal level, I see this outpouching that I was seeing in my subcostal view. This is a basal aneurysm. This is an infrabasal aneurysm, and this patient actually had an aneurysmal outpouching of his base. And then we put color Doppler on the mitral valve. And what we see here is there's severe mitral regurgitation. And we confirm again, there's severe mitral regurgitation. And so this patient appears to have severe MR, and his left atrium looks to be normal in size. And so what we did was we did a transesophageal echo. I put the TTE probe in him, And we confirmed. You tend to get much better resolution because it's higher frequency with TTE. And we confirmed that the patient did indeed have acute severe MR with a normal left atrial size, and that this was a new diagnosis in addition to the inferior basal aneurysm. And so we consulted cardiology and we consulted cardiac surgery. Now, mind you, this patient was actually in pulmonary edema from a cardiogenic cause. The patient did not have ARDS, as was initially thought. It was actually cardiogenic pulmonary edema from acute severe MR. And so cardiology decided to go ahead and do a quantry angiogram, which revealed double vessel disease, including the right coronary artery. And as we know, the right coronary artery specifically is the only artery, usually that's in right dominant circulations, that supplies the infromedial or the posteromedial pap muscle. The anterolateral pap muscle has a dual blood supply. It's supplied by both the circ and the LAD, whereas the posteromedial pap muscle is only supplied by the RCA. So when you have RCA disease, you tend to have posteromedial pap muscle dysfunction, and you can develop ischemic MR, which is what this patient had. And so cardiac surgery decided to list him for surgery. They just wanted him more stable. They wanted him obviously diuresed and more stable on the ventilator, extubated. And once they made sure that he was neurologically intact, he had his surgery. He went to the operating room 6 weeks later, had a CABG ×2 mitral valve replacement and an aneurysm patch repair, and was discharged home 2 weeks post-op. So this was a patient that was labeled as ARDS. Turns out that he actually had cardiogenic pulmonary edema, and point-of-care ultrasound was the modality that helped us reach this diagnosis. We have a second case here of a 28-year-old gentleman with a history of IV drug use. So this is a gentleman who's got a history of smoking, IV drug use. He's a chronic hep C patient as well. He comes to the emergency department with shortness of breath and confusion and a fever. Now, obviously, when you're thinking, okay, this is a gentleman who's using IV drugs, presenting with a fever, shortness of breath, your index of suspicion goes up, definitely for infective endocarditis. So we did this patient at this point was intubated and was transferred to us up in the ICU. And in the ICU, we did a point of care ultrasound. And this is our parasternal long axis. Nothing really jumping at us here, but let's zoom in a bit more on that aortic valve. And once we zoom in on that aortic valve, it becomes very clear that the aortic valve is grossly abnormal. And what we see here is one of the cusps of the aortic valve, and this is usually the right quaternary cusp because it's pointing towards the RVOT. The right quaternary cusp looks to be abnormal, and there is what appears to be a vegetation on the ventricular of this cusp. Usually vegetations happen on the low pressure chamber side. So usually that's where you'd normally expect to see a vegetation, on the low pressure side of the aortic valve. We put color on it, and there was severe aortic incompetence. And we also did a apical 5-chamber view, and that showed us that there was indeed a severe aortic incompetence jet. And so basically we stabilized the patient. With severe aortic incompetence, you need certain hemodynamic parameters to try to stabilize your hemodynamics and improve forward flow. And there was definitive management that needed to happen as well, given this new diagnosis of infective endocarditis. So in terms of hemodynamic stabilization, we're all aware of our hemodynamic goals for somebody with acute severe aortic incompetence. You need to keep your preload reasonably high to augment forward flow. You need to maintain normal pulmonary vascular resistance. Your systemic vascular resistance, if at all possible, would actually be better off on the lower side to improve forward flow. Now, obviously, coronary perfusion pressure takes priority. So if this patient's in shock, then you need to establish coronary perfusion, then you need their MAP to be high up. But if you're able to lower the systemic vascular resistance, this will increase your forward flow in cases of regurgitant lesions. Your heart rate, you want to be slightly on the higher side, anywhere from 80 to 100. Average of 90 beats per minute is where you want your target to be. You don't want a slow heart rate because this will increase your regurgitant fraction, and you want to improve forward flow, and you want to maintain contractility as well. And so for this patient, we obviously got a cardiac surgery referral, And they wanted still a cardiology done TTE, cardiology done transthoracic echo, which we did. And the patient eventually underwent an aortic valve replacement during that same admission. Okay, really quick here, I got a 68-year-old gentleman with a history of a valve problem. So this was a patient that came to us here in London, Ontario. He was an immigrant from Africa, and he, on history, said, I had a valve problem, but we had no medical records to understand what this valve problem was. And while we were assessing the patient actually sustained a cardiac arrest. And then after resuscitation from the cardiac arrest, this is our point of care ultrasound, we're trying to understand what this valve problem that this patient is telling us about or had told us about before he went into a cardiac arrest. And basically, this was what his mitral valve looked like. And this mitral valve looked like it's not opening very well. Remember, during diastole, it's supposed to approximate the septum. Here, during diastole, it looks relatively restricted. And so this gives us a very high index of suspicion for mitral pathology, specifically, potentially even mitral stenosis. And what you normally would see is a hockey stick appearance, where you'd see a long aspect of the hockey and then a short aspect here, and a bit of tethering, and the mitral valve is not opening like you normally would expect it to open. And on the same patient, we got a subcostal 4-chamber view, and this is what the mitral valve looks like, very calcified and not opening very well. So this patient got a comprehensive echo and indeed did end up being diagnosed with severe mitral stenosis during this admission. Now, obviously, this affects our management in the ICU. Last but not least, I have a 35-year-old female with known hypertrophic cardiomyopathy. This is our parasternal long axis view. I move on here to our apical 4-chamber view. And what I want to turn your attention to is that mitral valve. And what you see here is the mitral valve is entrained into the left ventricular outflow tract during systole. So it's creating a dynamic left ventricular outflow tract obstruction, or what we would call systolic anterior motion, or SAM. And this is something you would need to assess in any patient presenting to the ICU with hypertrophic cardiomyopathy, or any patient as well presenting post mitral valve repair. You tend to see that quite often. So in summary, basic cardiac valve assessment can be performed using 2D ultrasound and color flow Doppler. You can assess severe MR and AI, and you can detect that with efficiency at the bedside, and it will have therapeutic implications in patients with undifferentiated cardiorespiratory failure. In patients with suspected stenotic lesions, 2-dimensional focused echo can also help direct further management. And this is all I had. I just wanted to acknowledge my mentors in point of care ultrasound, Doctors Robert Ardfield, Ivan Iglesias, Dane Bainbridge. And I also wanted to refer our listeners to the point of care ultrasound textbook. This is a really comprehensive textbook that covers pretty much all aspects of point of care ultrasound. I contributed the valves chapter to this textbook, and there are more cases in this chapter and more multiple choice questions as well. So I would highly recommend for further reading the book Point of Care Ultrasound. This is my email for anybody who has any questions. I also want to refer you to our website, westernsono.ca. You'll find a lot of clinical vignettes and educational modules on our website. I appreciate your attention, and thank you for having me. I'm open to questions.
Oh, thank you very much, Dr. Hegazy. Really, it's a breathtaking presentation. And let me say, it's actually give us a bread and butter for this very important experience. I don't know how to say it. I mean, but actually, it seems that I'm very lucky because I don't have questions here, because I'm going to start my questions actually. So I'm going to take all the floor for my questions. First of all, definitely measuring the vena contracta really will be very helpful in order just to differentiate between the mild and moderate severe valve lesions, or regurgs. Do you think that the transesophageal echo would be more accurate compared to the transthoracic echo? The reason for that actually, because in very several occasions, we've been told before this surgery that the patient have a mild, and then we discover the moderate, or the vice versa. I mean, sometimes it's moderate, it becomes like really very trace. And so, what do you think?
Yeah, that's an excellent question. So, in essence, absolutely 100% transesophageal echo. It gives you much better resolution. The probes are much higher in frequency. And so you're able to detect with accuracy mitral valve pathology and aortic valve pathology very well with transesophageal echo. In fact, in both of these patients that I presented, we moved on to transesophageal echo for more detailed assessment. And it absolutely is much better in terms of image resolution and accuracy of attaining a diagnosis. There is one issue I'd like to point out here, though, is that you want to depend on the examinations, the echo exams that have been done preoperatively for most patients, because the loading conditions in the operating room change. After you induce a patient and give an anesthetic, you reduce the afterload, you'll make the mitral regurgitation look less severe when you reduce the afterload. And so a lot of times, and I've seen that in my cardiac operating rooms, I basically come in to do a mitral valve replacement on a patient with severe MR. I put my probe in and the MR looks moderate and it doesn't look as severe as it was advertised. And what I usually say is put your stock, put weight in the preoperative test, because that is done under normal physiologic loading conditions. Mind you, if you've only had a transthoracic echo pre-op and you haven't had a TTE, then that's a different story. Now you're comparing apples to oranges, because now you have a much better test to assess your valve. But if they've had a preoperative TTE that definitively concluded that the patient had severe MR, I would say I would put more stock into the preoperative test, just given the altered loading conditions in the operating room.
That's amazing. And another question for the, in order to diagnose the aortic dissections, especially type A, is it feasible? I mean, by relying on the transesophageal, the transthoracic, definitely with the transesophageal, it's going to be very, very easy and very feasible. But what about the transthoracic echo?
That's yeah. So I have images for patients with aortic dissection. Given the time constraints, I weren't able to show them, but maybe in a future talk. So yes, you can detect aortic dissection on transthoracic echo. However, you cannot rule it out.
Yep.
So basically, if you see it, then it's there for sure. But if you don't see it, because the descending thoracic aorta is usually in the far field, then you cannot rule it out. Sometimes if it's in the ascending aorta, you can, a parasternal long axis can sometimes give you a good view of the ascending aorta, and you can see it there. But as you mentioned, Dr. Ogamil, the gold standard here is obviously CT, but in the operating room, it would be a transesophageal echo where the resolution will be outstanding. You will see the dissection flap. You want to ideally find where the entry point for the flap is, and you want to see where the false lumen and true lumen is, and that will guide your cardiac surgeons. Cardiac surgeons will put a guide wire, at least here in this center, they'll put a guide wire and they want to know that their guide wire is in the true lumen, not the false lumen. And so they usually use TE for that. And maybe some other talk we can show images of that. But yes, can transthoracic echo be helpful? Yes, it can. But I would caution you not to rule out dissection based on a transthoracic echo. Obviously, if you see it, then it's there. But if you don't see it, then you have not really ruled it out.
That's wonderful. And for the HOCM, the SAM, or the systolic anterior motion, it could be detected, and you can something you can rely on in the transthoracic echo.
Yes, yes. I'd say most of the times we do detect SAM quite well with transthoracic echo. You're looking for multiple things with SAM. You're looking for entrainment of the anterior leaflet into the left ventricular outflow tract, as we saw in the image. You're looking for asymmetric septal hypertrophy or sigmoid-shaped septum. You're looking for sometimes MR, because that anterior leaflet, as it gets entrained into the left ventricular outflow tract, it will tether the chorda of the mitral valve, and sometimes you'll get an eccentric mitral regurgitation because of SAM. And so you want to assess very well for mitral regurgitation. You want to assess for the thickness of the septum, and you want to assess on 2D exam what the leaflet looks like. And yes, transthoracic echo a lot of times is sufficient, and but at the same time, in general, transesophageal echo is still what
gold standard.
Gold standard. I mean, you'll get much better images, much better resolution with transesophageal echo. That's for sure.
Wonderful. Thank you very much, really, indeed. And it was a really amazing presentation that ends really our session. I would like really to conduct my deep appreciation for the organizers of the mega online course, for our eminent speakers for tonight. It started with the Professor Sharif Sultan and with Professor Noha, and our dear Professor Ahmed Hegazy. And thank you very much. Perhaps, and I'll be really looking forward to see you again in many sessions.